Hello, and welcome to HFMA Talk, the podcast for NHS Finance. My name's Sarah Day, and I'm a Policy and Research Manager at the HFMA. This episode shares highlights from a roundtable that we held jointly with CIPFA, where senior leaders from across the NHS and social care shared their views on the future financial sustainability of the health and social care sector and the challenges facing integrated care systems. The roundtable was held on 21st July 2021. The Health and Care Bill had just had its second reading in Parliament, but the government's new plan for health and social care had not yet been published. Our chair for the session is Lee Outhwaite.
This is a joint roundtable between HFMA and CIPFA, which is a good thing to be encouraged in terms of intersectoral working between local government and health. Should be very de rigueur. We need to do more of it, one might claim. But it feels to me like a really timely conversation as we all try to make sense of the Health and Care Bill and how this thing might maximise value and the extent to which we might be able to convert some of the illness service that is the NHS into something that's a bit more orientated towards health and well-being, and how we go about doing that given the joint roles between local government and the NHS and how we navigate our way through the excitement. I imagine it would be helpful if we did a round of introductions from delegates, and I'll use Chair's prerogative to introduce myself in terms of what species you're dealing with. I'm Lee Outhwaite. I'm the Director of Finance of Chesterfield Royal Hospital. I am also the ICS Finance Lead for Derbyshire. In addition to that, I'm a trustee of HFMA and I'm their trustee lead for policy and research. And in addition to that, I think I'm on CIPFA Council and I am Vice Chair of what is about to be their Public Policy and Reform Forum. So I'm institutionalised in NHS finance, but I've got more than a hobbyist interest in how we partner with local government differently around health and well-being.
Okay, I'm John Jackson. I'm the National Care and Health Improvement Advisor for Finance and Risk within the Care and Health Improvement Programme, which is a programme funded by DHSC but overseen by the LGA and ADAS.
Yes, so Councillor Tim Swift. I'm the leader of Coaldale Council, which, for those who aren't familiar with the name, is council around Halifax in West Yorkshire, one of the 5 West Yorkshire metropolitan councils. We're one of the smaller Mets by population, but larger by area, as we had a large rural part. I chair the Health and Wellbeing Board there, but I'm also the chair of the partnership board of the West Yorkshire and Harrogate Health and Care System, which is our ICS, and effectively our partnership board is a bit of a model for what's set out in the legislation.
Yeah, morning everyone. I'm Nikki. I'm the Director of Finance and Governance at the Leicestershire and Rutland CCGs, and the ICS Finance Lead for Leicestershire.
So I'm Alison Henley. I'm Director of Finance for Somerset CCG. I also cover contracting, primary care and digital within the CCG as well, and definitely working across the system, both in terms of the ICS role and working with our local authority in terms of how do we do things differently going forward? Where are the opportunities that are coming out of this? So it'll be great to pick up the questions and have the discussion.
Paul McKevitt's my name. So good morning everyone. Yeah, I'm the Director of Finance at Wigan Council. So I've been Director of Finance at Wigan Council since 2008. And I'm also the Director of Finance for Wigan Borough CCG, which I've held that post since 2018.
Andy Harley, I'm CEO at University Hospitals Coventry in Warwickshire. Up until the beginning of this month, I was actually the exec lead for the Coventry Warwickshire ICS since its inception back in 2016, but I've handed that over to the AO of our new merged CCGs. And I'm immediate ex-president of CIPFA up to a couple of weeks ago, so I'm still on the board of CIPFA. And if I go back in history, I was president of HFMA back in 2014. So I'm really pleased that HFMA and CIPFA work together on this. I think it's the right thing to do.
So I'm Cathy Rowe. I'm Finance Director for Tameside and Glossop CCG and Tameside MBC, holding the Joint Director of Finance role and the Section 151 role. Been in that joint role now for 4 years almost. So yeah, that's gone quickly.
Sandra Beard, I work for CIPFA. I'm a fan advisor, which means I financial advisory a financial advisor for local government, but I also run the social care network for CIPFA, so I also advise social care practitioners in local government. So I'm very interested in understanding more about the whole sort of like, you know, white paper integration, everything from a local government point of view, how it's going to affect my customers. And obviously in order to do that, I need to also understand how it affects national health and how we're just going to work together.
Well, it looks like we've got through the second reading, doesn't it, of the bill? So it looks like we're going to have landed it by the 1st of April next year. If we're genuinely going to get into triple and quadruple aim and working very differently around health and well-being, how is this thing going to facilitate it? And what else do we need to do? And what are people concerned about? Should hopefully kick the conversation off. John, come on in.
I mean, there's not necessarily anything wrong with the bill. It just doesn't go anywhere near far enough. And I think for me, at a personal level, I was quite excited by the 10-year plan for the NHS. I thought it was saying all the right things, which a lot of people had criticised the NHS for. It was trying to talk about the whole population. It was looking to go for a strategically different approach, which wasn't relied on bed-based care. And I think that was really exciting. And this bill just deals with a very, very small part of it.
I'm going to go Kathy, then round to Tim.
Thanks, Lee. Being a bit Greater Manchester about this. At first, when we first saw the precursor, if you like, to the white paper that came out, and it was talking all the right language about partnership working, place-based working, it was all about, you know, looking out for population health management, and all the right words, all the right phrases were in there. It did feel quite exciting. It felt very much, it spoke the language that I think Greater Manchester under its devolution powers have been working in that spirit for obviously the last 5 years. And it really felt like we were onto something. It felt like it actually picked up some of the language from the GM documentation in it actually. When we actually saw more around when the white paper came out and the consultation that was there and the governance that started to be put in place, I have to say, I think everybody drew in a sharp breath and felt probably quite disappointed by it, because it felt very much like the NHS had put a wrapper around NHS funding and tried to take it off into someplace else and have a separate board, an NHS body, an NHS board that was very much talking over here around NHS conversations and NHS funding. And yes, there is a partnership board underneath which will have lots of partners on it and local authority partners on it, but it just didn't feel like it was in the spirit of what that document was talking about, that was the precursor to it. It felt like we've gone backwards.
Kathy's captured some of my thoughts about this very well. So the original conversations that led to the legislation were very much talking about what's the minimal changes to let us do the kind of things we'd started doing as a partnership. You know, how can we build a genuine partnership of equals between local government and health? Because if our real concern is about the well-being of our population, it's not even about just joining up health and social care, it's about all the things that local government brings to the table. And whilst we could see a need for a legal NHS body, that's really about the formalities of then delivering that, and that's not the balance that's reflected in the legislation.
Thanks, Tim. Very helpful. Round to you, Andy.
Before the bill came out, I was saying I was very much in the mind that I don't want it to be too prescriptive and to be permissive as opposed to prescriptive. I think there's a danger that it's gone too far away from being prescriptive, and it's so loose that whilst we could get bound up in governance, as Kathy said, actually, and I'll say this as a provider, chief executive who believes in integration, who believes in working with social care, etc., I could just stand back really and sit around a table and nod occasionally, because there's no levers in there except for capital as far as I can see, because I'm not an FT. So that is a danger. This is going to rely on a lot of goodwill from a lot of partners. And then falling on to Kathy's point, I do think that the bill as it's been drafted has actually affected some of that goodwill and some of the work that's gone on to date. The guidance comes out, and just as Kathy said, well, oh, so over here you're going to talk all NHSC, where are we just over here, nice touchy-feely partnership board? And it's, I'm not saying it has knocked everything back 5 years, but it has knocked it back.
Thanks, Andy. And I think we're on to Sandra next.
Thank you. I was very pleased to see that, there's a strengthened role for local government in it. I think it has been felt for a long time that local government were kind of like the poor relations in a sense, and we were just paying lip service to it. So the fact that there's now going to be a legal requirement for local authorities to be on the board, part of the governance arrangements, hopefully that's going to mean they've got far more clearly defined role. Hopefully they'll have a stronger voice in planning, the allocation, etc. So that's the bit I do like about it.
Nikki, do you want to come on in next?
I think, when we first heard about the paper, it was talking about a duty to collaborate. And I noticed by the time it came to publication, it became a duty to cooperate. Well, that's where Andy talks about the levers being completely removed. And I think that's it's worrying that they didn't go whole hog on it. The second positive is moving primary care to a provider. It's, primary care absolutely needs a shake up. So moving that to a provider, I think, and taking the commissioning element off the table is a real positive in this bill. And the third positive is around removing the competition and procurement rules, because, that's so time consuming. I know that there's negatives around that, around making sure we understand value for money and all of those other things, but it does allow us to work with partners much more collaboratively within the system. I think some of the downsides for me, the first one, there's no long-term settlement for social care. So we can talk about having a long-term funding solution for the NHS, but unless we do something with social care, we're not ever going to be on the same pitch. The second really for me is that the funding arrangements haven't changed. Yes, we can talk about blended payments and moving away from PBR, but actually the allocations are still driven by something none of us have ever understood. And if we're being serious about health inequalities, why aren't we looking at the way that we fund the NHS completely differently?
Alison, come on in.
I share some of the sense of disappointment between what we were expecting and what was set out originally to where we got to then when it went through the sort of the bill. I think actually for me, it in some ways it set a sense of direction and a permission to get on with things. So there's a little bit for me about how we do things around this. It is broad. It doesn't give us, the absolute detail, but it gives us the permission to get on and do things differently. The worst thing for me is if it became a change of name above the door. That would be the worst thing.
Thanks, Alison. And John, last word on this issue before we move into social care funding.
The discussions I've had with local authorities, there's been generally very positive feedback about the way relationships between social care and health have developed during COVID. Because as somebody said in a meeting I was in the other day, there's been a common enemy. And I do wonder, and that's nothing to do with legislation. It's to do with people focusing on what is most important and thinking about how they respond. And I think, again, that's something we need to take stock of in terms of the more general issues rather than just the legislation itself.
Agreed, John. I guess my attempted synopsis around this is, my sentiment is around the does it go far enough? I think it probably gives us permission to go as far as we want to go, contingent on those relationships, which are probably slightly more important than what somebody's going to say in a somewhat abstract document in the House of Commons than the House of Lords. Big question, and the next question, which Nikki's identified, is just this social care reform, social care settlement. What are we going to do between free at point of need, between means testing, and the somewhat difficult divide that creates between health funding and social care funding? And in the absence of that, is it such an enormous impediment to joint working? We struggle a bit. So we're moving next, we're urged, and sensibly so, into the issue Nikki's raised about social care funding settlement. Come on in, Paul.
This is a big problem really for us, is around social care funding. So I think the bill doesn't understand the history. So what you've got is councils are funded differently and have been affected differently by austerity. So each council's coming into this in a different position. So some have dealt with the cuts, some are still using reserves. So you've got councils facing massive issues financially. That's the first issue. Then you've got councils that for the last 2 or 3 years have been on 1-year settlements, so have struggled to kind of do any planning. So they're going to be coming into the white paper or the bill once the bill's finalised next year and the back of these problems. And until you deal with social care, like you're saying, nationally, you're not going to have a a first system across the piece. So that's the big issue that they've got to bite really before you'll get councils, for me, fully engaged in this.
Thanks, Paul, and I'll go Andy then Tim.
Without a doubt, those of us in health are fully aware and support the fact we've got to get an adequate funding settlement for social care, because it's just gone way too far. But one thing that I think the pandemic has put the spotlight onto more than ever before, but most of us understood it anyway, is just how interdependent we are. And that in terms of the, as somebody mentioned earlier, the customer, in terms of the populations we serve, we're one public sector, but it's very confusing. I'd like to go even further and say actually we have place-based budgets which have got to be bigger than they are now, but it's just like one set of money, £1, and how can we spend that most effectively, whether it's in health or in social care?
Agreed, Andy. Round to Tim, then back through to Sandra.
Thank you. So yes, very much following up Andy's points. There's a load of issues about social care funding, obviously, and working as cooperative partnerships. The thing we should be able to get rid of is the kind of handing bills on to each other. So kind of the competitive deciding about who doesn't qualify for continuing care funding, for example. You know, we can all spend lots of time basically just passing the bills between to each other, and that helps nobody. But the bottom line is there isn't enough money available for social care. We need two things. We need a short-term fix, because we need more money going into social care now, and we'll probably touch on some of that when we come on to the COVID stuff. But we then need a longer-term system that fairly identifies where additional resources for social care are coming from. And just final point in terms of the older people selling the house to pay for the care thing, it's worth remembering that currently about half the social care budgets don't go on older people anyway, they go on people of working age. Oh, sorry, if I throw one other thing in, Paul touched on the impact of austerity and lack of funding. The other thing that's worth bearing in mind is the current fix the government has, which is the social care precept, is itself massively unfair, because a 1% social care precept raises much more in some parts of the country than others.
Thanks, Tim. So Sandra, you coming in now.
Hi, thank you. Yeah, I think the problem with social care funding, I think the problem is, obviously, yes, social care is underfunded, but it's also part of the bigger picture, which is that local government generally is underfunded. So you've got local authorities, and obviously we have the differences as well. Local authorities have to set a balanced budget, so we can't budget for an overspend, which means that the more we're having to pour money into social care, because that's where it's needed, because that's where a lot of the statutory duties lie. It means that the non-statutory areas are being desecrated. It means that preventative services aren't being funded anywhere near as much as they should be.
Thank you, Sandra. Kathy?
Thank you. So, yeah, this is a real knotty issue, isn't it? And we have put in place a place-based budget for the totality of the funding in the council and the CCG over the last few years. We started off with just health, social care and public health, but we realised that we were having conversations in different rooms and missing the point here, because it was the other things that we could have a conversation around: housing, education, employment, etc., that could help address the pressures that were in the other room. So we threw the whole thing in. We still had all the decisions, everything in sight of everybody. So it was basically £1 billion in sight of everybody gross. What we did, though, was draft a key set of principles, because we recognised all we were having conversations about 4 or 5 years ago was the detox, and people stuck in beds and couldn't get out, and the social care system wasn't fit for purpose, etc. So we tried to address that by creating some principles across the local system that we wouldn't cost shunt, but that we would do the right thing for the patient and the person there. And that did help take away some of the tension. But actually what we were trying to do, and we never quite got them, we were just about to go and try and take this a step further when COVID landed, we were going to try and transfer the whole social care staff into the local foundation trust, because we actually felt it might be the choice of the system to spend more on social care, because actually it would free people up out of the acute beds by doing that, to get people more in the right part of the system. I've not got a solution, I'm afraid, to it all, but I do know that we can do more with what social care offers in the future.
Thanks, Kathy. I think it's really interesting, that dual role you've got between looking at the slight nonsense of what we do in terms of funding within the NHS environment versus that Section 151 officer back at the ranch, where I think it's a bit easier to see some of these trade-offs. So really insightful, and thank you. I'll go John, and then I'll let Nikki have the last word.
The starting point, which has to be fixed, and this is clear in both what ADAS and the LGA have been sending in their spending review submissions over the last couple of years, is we need a sustainability of the existing system, which broadly means some providers need more money for what they're doing now, because at the moment what's happening is not right. The second thing is that there are issues of unmet need. There are people with legitimate needs whose needs are not being met, not deliberately by local authorities, but that needs sorted as well. The fact is, every year, the financial pressures on adult social care are going up by at least 7% a year. That's about 3% for demography and 4% for inflation. It's high for inflation because the national living wage is going up so much, right? So there's a 7% annual increase that's around, on top of the first two things. Both the LGA and ADAS have recognised the fact that care workers must be paid more, that has to be done through something like a special national living wage, right? But the fact is that will need funding. Now, all of that together is a huge amount of money, right? It's not a couple of £billion, it's several £billion, right? Probably 6, 7, something like that. Some of it we haven't been able to cost yet. But the point is, policy changes will cost money on top of that. And that's why when Andrew Dilnott talks about this, he talked about 10 billion. I think as a rule of thumb, that's a pretty reasonable sum of money for us to talk about. I'm not even sure, though, that would be sufficient, I have to say.
I think we need to talk about the funding model. Everyone's mentioned it, but, we sorted mental health out by ring fencing that funding within, local authorities, local government. The two final points for me is the hospital discharge programme, how quickly it worked. I'm not sure if we all looked at what we spent it on, whether it was the right thing, but actually, surely that's an indicator that solved a problem using funding and taking away some of the barriers and boundaries between what becomes health and what becomes social care, and the arguments that fall in between, and the time that potentially takes. And then the final point is really that costs for social care will continue to increase unless we get the prevention, the health inequalities, and ultimately children sorted. If we don't start, the first 1,000 days, we don't start that right, then the rest of the process is gonna be wrong from there on. So I think that we've got to. And my worry is we discuss so much on social care, and once people are in social care, it just becomes a really costly exercise, doesn't it? But if we don't put the same amount of force, energy, money into prevention and health inequalities, then all we're going to get is this exponential curve.
Thank you all. So I think there's this 10 billion or whatever yawning number that needs some sort of funding source that we all kind of concede. And in the absence of that, it does feel as if there's this kind of looming crisis that's kind of slightly unresolved, which it's going to be difficult enough, isn't it, to start all focus on narrowing gaps in healthy life expectancy. I would claim some of that would be a bit counterintuitive to the NHS. It isn't historically what we've focused on per se. But if that's what we're really about, there is that yawning social care funding crisis that needs to be resolved in some which way. So who wants to go first on population health, broader socially determined disease? What outcomes are we really after? And are we really serious about this is my challenge, because I think Andy's right. It's quite easy for people like me that sit in an acute hospital to look at their health and care partnership now and go, well, good luck with all that. That's all a bit complicated. Who's got what role in this exciting new mission that we should always have had, but perhaps we haven't had as fully as we needed to? Andy, I think your hand went up first.
Okay, yeah, thanks, Lee. My hospitals, like yours, are very good at making people better when they're sick or something's gone wrong. But I think the whole attitude towards thinking about putting the H into the National Health Service is really changing now. A barometer for me was 6 years ago, I approached the then local Director of Public Health saying I'd like us to discuss having a joint post, public health consultant post, between the hospital and the local authority. And I was frankly dismissed. That wasn't my role, and they didn't see how that would work. I've now got a public health consultant in my organisation, which is joint with the local authority. only been with us a handful of months and making a massive difference in terms of getting into people's heads and thinking about what we can do as an acute hospital. We're, within Coventry, we're a marmot city, so we've got big health inequalities, and so it's heavily on our agenda. I suppose so. I suppose my key message is we do get it in acute world. Let us get involved, but we do need help and steer in how we can make a difference.
I think Andy's picked on my first point, which is the links between public health and where they sit in that ICS space. They're absolutely critical, and they're critical at place. And I think the public health particularly need to be driving a lot of that place conversation around how care is provided. The other points really for me is around to do it, we need to have really good population health data, and we don't in the NHS, but they do in the councils. So how do we maximise that information and use that to start to really build the information that we've got, and then the actual care that we provide on the back of it. It has to be linked to funding. Lee knows we're completely changing primary care funding to be based on population health over in Leicestershire, and it has to drive some of the, particularly the discretionary funding, because unless we do, actually, when you look at it, the Cahill formula actually drives health inequalities. It gives money to those that are older and weller. So it's based on age. So funnily enough, those areas with the lowest health inequalities are getting the most money from primary care at the minute. And so how is that ever going to drive a reduction in health inequities?
Thanks, Nikki. Over to Kathy.
Thanks, Lee. So as part of the work we've done locally, we've created an integrated care organisation through our foundation trust a few years ago when it was having some really difficult challenges, and over that time period we've tried to move away from like the contracts that we've had in place for the last few years, and on PBR we took all that away, and we've tried to move it slowly towards outcomes-based contracting. It's really difficult, and as you say, Nikki, in the type of arrangements on the contract we've been given, it's not been easy. But I do think that is something in the ICS white paper, that it does absolutely refer to the expectation of a longer term agreements and contracts being in place. So that for me was a positive. And if it was me, and it's great what Andy's just said, because what I was about to leap in and say was, for me, I think in the new world, commissioning is not going to be commission. Commissioning is going to be an old phrase, isn't it? And providers are actually probably going to be more equipped and take on probably commissioning staff and be more equipped to deal with some of this. And I would like to see providers, and again, providers will change that language. I don't think it will be providers as we know it today in the traditional sense. They should become more responsible for population health management, and absolutely have directors of public health or whatever on their boards, and other governors and other changes to their constitutions, I think, to make them feel like they are responsible for that population and health management on behalf of their residents. I think providers, as they are traditionally not called now, and commissioners will be blended into some entity that is more into design and delivery, and they'll work much closer with local authorities, is the intention and the hope anyway as we go forward into this new ICS world. Ignore the governance at the top, create our own place-based governance that makes that happen. And I think that's where we'll get the value out of what we're trying to do going forward, over that money that's available to the locality, whatever gets delegated down to those localities in the new world.
Tim, come on in.
Yeah, so I've certainly been very pleasantly impressed by the extent to which as I've got more involved with the ICS. I found providers recognising the wider determinants and really keen to challenge us on what we're doing about it. I think the challenge is how you find a funding model that encourages the shift of resources, because sometimes we're talking about things that actually will reduce demand in 10 and 15 years time, and you've still got to cope with what's in the system now. But equally, I think there are different approaches that do have more immediate shorter term impacts, and a lot of it is this focus about, particularly as people become frailer and vulnerable, we want to do the things that enable them to live the fullest life possible, and that isn't always about high cost medical interventions, or indeed about high cost social care interventions.
Next question is about how we make these reforms more effective. We haven't really talked about third sector building community capability and capacity, building community resilience, thinking through a little bit more about how social enterprise and the third sector fit into that. That third sector and what we do about building community assets and community capacity, it feels a bit silent in the bill to me.
There's this phrase called strengths-based approaches to assessments, where you look at people's strengths, which is not just their personal strengths or their strength, the support they might get from their families and friends, but it's also about the community. And I think for me, that's where you need to see it. It's not just a question of simply saying, you know, because the slight difficulty with the voluntary sector will say, we need money, because they operate on a business model which is broadly about, you've got to get funding in to enable things to happen, and they will be very passionate about what they want, but the real question is whether that works in terms of what they collectively decide are the key priorities in an area. And so for me, it's a means to an end, and you need to be clear about your end, but then you need to be very open about the means.
Thanks, John. Kathy, come on in.
Well, it's a huge part of it, I have to say, because we can't afford the health and care system that we've got now. So unless we develop a community-based asset approach that will be heavily involved with the voluntary sector, but also with our other partners, whether it's the police, the fire service, you know, the schools, everything, the neighbourhood needs to be much more than what we might have thought was in scope of a neighbourhood previously. And the place-based working and the integrated care system white paper is alluding to that's where the direction needs to be, isn't it? We could do so much more if we had services or things in place that could support people to live better, live well at home longer than what they are doing. People tip up into the system because there's nothing else for them to go to. So there's somehow we have to flip that, isn't it? And we've been trying to do that. We've been trying to do so much social prescribing, which is one of those things that's really difficult to evaluate and say to everyone how fabulous it is. We get some really positive personal feedback from people who've been stuck in, and loneliness is a huge issue, and that's why people again end up in certain parts of the system, and people with lots of mental health issues. And we know coming out of COVID, that's going to be exacerbated even further, and we're feeling it very acutely at the moment. We need to really focus on those cohorts of our communities that really need help and support, because that's the way where we manage the treatment costs and the need costs coming into our health and care system in the future. If we can support those people going forward much better through these voluntary sector organisations, through the social prescribing, taking people to do things they want to do, not what we think they want to do.
Thanks, Kathy. I agree. I'm very impassioned and well said. I'll go Nikki, then I'll go Paul.
I think that we are sometimes a bit arrogant in that, thinking that we know best, because we think, you know, that old ways of people accessing services such as primary care are important, and actually they're not. What's important is their local religious groups, their, you know, where they go, where they shop, all of that stuff, and that is absolutely known, you know, by the voluntary sector. So I think we can't ignore what happened in COVID. If we go back to traditional ways and routes of people accessing health and social care, we've absolutely missed one of the biggest learning points that we could have got from COVID.
Yeah, it's just an example of working with the voluntary sector. So what we did was recognise that if we were going to take money out at the start of austerity, we had to look to the voluntary sector to fill gaps. So we came up with a different way of assessing our social care packages were around not your traditional way of care, but about what you can do for yourself. But to enable us to do that, we had to invest in the voluntary sector. So we set up a funding mechanism called the Community Investment Fund, where we looked to grow those areas to allow us to take the money out of social care. And that kind of helped us really engage with the voluntary sector and understand what the issues that are there. So we took about 20 million out of social care, but actually improved the kind of services that we provide. And it allowed us to invest in reablement. So helped us in terms of what we're doing with the hospital around discharge to assess.
Thanks ever so much, Paul. We're moving on now to a question that we may never emerge from. Where should funding be focused to achieve the greatest impact? Good heavens above. What an open-ended question. I think you need a PhD in statistics to understand how the national funding formula for the NHS works. So we're going to target the funding in a different way, perhaps jointly. And is there a more fundamental debate we need about some elements of local government funding and certainly elements of NHS funding to act as an enabler for that? Open question.
Okay, I think it's one of those $64 million questions, or probably 64 billion actually, isn't it? I think splitting it down 2 or 3 different areas. I think there might be short-term, long-term, and actually transformation, if that's in between. I noticed Kathy's comments around how the transformation fund works or worked in Manchester. I think that's really important to give that sort of headway and headroom, as one of the members mentioned earlier. There are short-term issues, and I will talk colloquially for the NHS. You know, if we don't get some short-term, a lot of money in to sort out the backlogs, we could just be strangled by those backlogs for a very long time and not think about anything else. The transformation, making some money available, which is not too prescriptive, it is permissive, as Kathy said, around making some transformation, because we locally know what we need locally, rather than being prescriptive. And then I think there is the long-term issue, without a doubt. We've talked about social care already. It's woefully underfunded. I've stood on many public platforms as an acute chief executive, so that for years actually, before STPs came along, because they're going back to my earlier point, we're all interconnected and we need it. So it could be more radical, as it also said earlier, about, so what does my city or my county actually need within whatever the pot is? And also picking up your point around, I used to think I understood NHS fund allocations. I've lost it a few years ago now. So we need some transparency around that. But actually, capitation budgets for all of us will be the way forward at a place base.
Thanks, Andy. I'll bring Alison in then, John.
The one I wanted to start with was the thing about how do we make our best use of our pound. So actually, when we invest, how do we get that greatest use of the pound? And I think in terms of where we are, we've got a number of things going against us, and it's how do we get those to change and develop as we go forward? For me, we had contracts, we've now got block contracts, don't know what's going to happen in the future, but what does that funding framework look like in order to incentivize the right behaviours and to look at the right things? And I'm not talking health, I'm talking about how do we get the right use of our pound. We talk in Somerset about what's the right use of our Somerset pound, whether it's health or care funding. What is that right set of incentives, and what do we need to do around it? Because otherwise funding always becomes a blocker. So how do we make funding and finance become the enabler going forward?
Thanks, Alison. John, you come on in.
I think social care and local government need to recognise if somebody's not having their hip replaced, there's a much greater chance they'll need personal care. So we're in this together, and it does come back to a theme which I think has been throughout the morning, which is we're in this together. The only way forward is for us to work together. And frankly, I'm really impressed with other people on the call about how committed everybody is to the same agenda that I'm interested in as well. And I think the real question is, how do we make that happen? And Tim, if you don't mind me saying so, there's quite a big onus on people like you, because as the leader of a council, you should be the community leader. And I think the more other leaders can do exactly what you're doing, and I know a lot of leaders do this, I'm not having a go at leaders generally, but the more you could do on that is crucial to taking this forward.
I absolutely agreed. The penultimate question is just about long-term financial implications of delivering care in the context of COVID, both the NHS and local government. I think we've started to touch on this, haven't we, really, about reality of post-illness settlements. Is there something about getting RTT backlog out of the way that perhaps there's a slight skewing effect there about sort of social access to 18-week type services, and does that slightly get in the way? How are we triaging that to look at the sort of equality impact of clearing that backlog, perhaps conceding fully that if you've been on a waiting list for a year to have your hip done, it isn't ideal. But I guess there's the broader question then about how well do we understand that financial settlement? We're going to have to get into sort of multi-year financial allocations, aren't we? Because if we're trying to do long-term stuff, not knowing what funding we've got on the 1st of October in health isn't entirely helpful. Local government never understanding how much money it's got till the 11th hour isn't helpful. There's perhaps a broader question, isn't there, about a longer-term funding settlement and what that begins to look like, and how then we can perhaps come up with a longer-term plan that's more longer-term because it's informed by settlement. Anybody want to come into the sort of broader long-term financial implications of delivering care in post-COVID and in the context of COVID, and what we might need in a funding sense to deal with that? I've pointed out some of the problems, but I haven't got the solutions.
I don't think I have all of the solutions, to be honest, but if I did, I wouldn't be sat here, I guess. I'd be in a different job. But the key thing for me, I think we need to split the next 10 years down. There's going to be a 2 to 3 year recovery. And if anyone thinks it's going to be any quicker than that, we're all kidding ourselves, because winter's going to come, flu, everything else. So I think we have to keep talking in those sensible terms. People say 18 months. I think that's a stretch. There are some parts of the country that, again, at winter and everything, are going to be hit more badly, worse than anyone else. So I think we have to talk in 3 years of a recovery, which a lot of that will be non-recurrent in nature. There's secondly the recurrent impact of long COVID, and we don't know about that, do we? So I don't think that none of us are scientists sat around this table, I don't think. But we just don't know on that one. That's got to be a watch and wait, but it's surely not going to have a positive impact. It's going to have, impacts on COPD, all of those respiratory areas that we already know are fully stretched. For me, with regards to funding, I'd like to see something to be done differently with Health Education England, something joined up with local authorities around workforce. We've got to crack this nut. Because otherwise, actually, we're not going to have provision of health and social care really until we start to make those careers. I know some of it, social care, is around the living wage, but actually there's much more about the different roles that we need to have across health and social care. Andy touched on some of the public health bits at board level, but actually this needs to be a root and branch, and just throw in saying there's 50,000 nurses and however many GPs is not the way forward.
For me, there's two other things to bear in mind. One is we've done an awful lot of good through COVID in how we work as well, and we must make sure we don't lose any of that as we go forward. So we do a lot of things more digitally, online. We've opened up a lot more access points. It's easier in some ways to see somebody for a lot of people. I know not everybody's online and digital savvy, and all of that will need to be accounted for somehow. People still need to see people when they need to on a face-to-face arrangement, but that will help massively, particularly as the next generation comes up, particularly like Nikki said. There's a generation there that people don't want to necessarily see somebody face to face or go to primary care, but if you can have a chat with somebody you think is someone you respect their opinion of online, we could probably do a lot more on seeing the level of activity that's out there. So we mustn't lose some of those advantages, because they will drive forward a lot of efficiencies as we go forward and manage people and the public's expectations also.
And finally, we've talked a lot, haven't we, about partnership working. We recognise fully, if we do this well around healthy life expectancy and life expectancy, we will be working differently between the NHS, local government and the voluntary sector. I think because it's permissive, this is far more about relationships than getting the legislation right. So I think there's a huge opportunity there. Self-evidently, if we're told to do the wrong thing or given an absolute prescription on doing the wrong thing, we won't do the right thing. But what are the other barriers we need to unlock? What are the barriers to partnership working that we haven't already identified? Tim, come on in.
I think the fundamental thing is understanding that those of us who feel we're trying to make ICSs work, it's not really about the formal structures. It's the time and energy that's gone into building partnerships. You don't have a partnership just because you have something called a partnership board. And ultimately, you build an effective partnership by doing things together rather than by obsessing about the rules. Although I suppose my one proviso to that is, actually, if you've got a decently working partnership, this is the time to get the rules right, because the only time you need a constitution is when things go wrong. So there is a bit of a balance there, but creating the culture, that's what it's all about.
Agreed, Tim. I'll go Andy, then Kathy, then John.
Yeah, thanks. I totally agree. It is about behaviours more than anything else, because you can have the best structure in the world or the worst structure in the world, it's irrelevant. And I think actually some of the bigger challenges come on the NHS side, where actually people have talked about financial incentives and the way the operating framework has worked in the financial environment. Foundation trusts have really not been incentivised to act in a partnership manner over the years through PBR, etc. And and we have to accept some of that behaviour or methodologies of working is very deeply rooted. And so I think that the behaviour and challenges are actually bigger on the NHS side, and we just have to be really open and honest about that, those of us who work in the NHS, and try to explain that to some of our other partners about how we've got to where we've got to. The provider commissioner split, I'm pleased, as somebody said earlier, it has basically gone, hasn't it? But again, that drove behaviours.
It did. And thank you, Andy. Kathy, then John.
We have a joint chief executive over the council and the CCG, which is really helpful. But we have a new leadership management relationship with the Foundation Trust, and how that's come together. It is absolutely all been about relationships and trust. They're the two words I use with everything in terms of what has helped us change the culture and the understanding of with everybody, with the pull about what we're trying to do, what is the offer that we're trying to put out there, what we are trying to do our best with the resources. It's never enough, is it? But it has absolutely been all about that, and we understand each other's risks better, and we share those risks. And that has been the thing, again, that has just made us come together and be so less adversarial around everything. We're very open, we're very transparent. We share all the finance information between each other on a regular basis. We do joint finance reports. We understand when we've got problems, we raise them early. We have our management team speaking to each other constantly every month. We deal with issues, breakthrough conversations if we need to. It's not perfect. We still have issues. We still have people who want to go and have a fight with the other one over things just because that's what they're used to doing. But we have to stop and rethink and go back and go, hang on a minute, because we know the two leaders at the top, they can't get a piece of paper between them. That's how it works. They will not go into that mode of battle again, because they know we're all trying to do the same thing, which is improve the outcomes for our local population. So we're no point in fighting about it. We are still all trying to do the same thing, and we all don't have enough money. So no point cost shunting between us either. So we come at it with a completely different approach, and that broke down loads of barriers that had been there previously. But it is about communication constantly at the top and setting that standard for the rest of the staff beneath you. It just changed everything.
I think it's not perfect, is it? But that act does give us a framework to work differently that we should welcome. I don't think it's perfect, but it's never going to be. So my view of the act, and I think where we almost got to, was it ain't perfect, but it gives us a framework to work differently. I think there's an absolute recognition we've got to work differently if we're going to kind of face into socially determined disease. And we're going to have to partner very differently between the NHS, local government, and that voluntary and third sector in a way that we haven't done previously. All it remains for me to say is thank you ever so much for sparing the time. I think it's been a really rich conversation, apart from my contributions, obviously. But thank you for spending the time having the conversation.
Thank you for listening to HFMA Talk. You can find the full write-up of this roundtable session on our website, www.hfma.org.uk. Don't forget to subscribe to this podcast to keep up to date with new episodes.